Hello, my name is Lauren Taylor, and today I'll be presenting on the paper Misfires, Misdata, Misaligned Treatment, Disconnects in the Collaborative Treatment of Eating Disorders. Patient-centered approaches to mental health treatment hold the potential to unite the patient, clinician, and support network in providing the most holistic method of mental health treatment we currently have. Over the past 2 decades, technology has come to permeate these collaborative treatment arrangements. Within the CSCW area alone, a rich body of work has studied coordination of and communication among treatment teams within hospital settings, as well as how existing or new technology facilitates or hinders these practices. As more individuals manage their chronic illness outside of inpatient hospital settings, there's a critical need to engage with the patient in order to understand collaboration from their perspective, as well as to unpack the interplay between their efforts and different stakeholders in everyday illness management. Eating disorders present a prime case study in collaborative healthcare due to the interplay of both psychological and physical health that necessitates a team of clinicians and support network members to support recovery efforts. Given the sensitive nature of the topic and the illness, we did encounter some challenges in recruitment, due to which our recruitment channels included both offline and online means. After screening for our inclusion criteria for both patients and clinicians, we ended up with a sample of 9 patients and 10 clinicians. With these participants, we conducted in-depth semi-structured interviews following a general protocol. After interviews had been completed, transcripts were then coded using an inductive analysis approach, which drew on constructivist grounded theory and similar qualitative analyses methods. Through this method, we were able to identify overarching themes in the codes. We identified 5 main themes surrounding disconnects in treatment through our coding. The first one being isolated clinicians within treatment teams. 2, the separating of physical and psychological dimensions in treatment. 3, divergent orientations towards tracking. 4, social support and social detriments, and 5, illness versus personal identity. In the interest of time, I will only discuss 2 of the 5 identified disconnects. The first disconnect we discovered in the treatment of eating disorders was within the clinician team itself. This team generally consisted of a therapist, dietitian, and primary care physician. However, these 3 specialists rarely communicated with one another regarding the patient's progress or recovery status. The disconnect between the clinicians and the treatment team often forced the patient into the role of an intermediary to relay information from one clinician to another. The disconnects in the treatment team went as far back as the patient's initial diagnosis of an eating disorder. It was common for patients to initially seek out the help from their PCP, but it was common to see that the primary care had limited knowledge concerning the treatment and identification of an eating disorder. This often resulted in the delaying of needed treatment for the patient. This disconnect within the treatment team proved to be crucial. Eating disorders are a unique mental illness as the patient's psychological recovery is directly linked to their physical recovery. Thus, administering a cohesive and effective treatment plan would likely require close communication between specialists responsible for fostering both aspects of recovery. This disconnect both stemmed from and reinforced a distinction between the physical and psychological aspects of an eating disorder. A disconnect that we found to have reverberating effects throughout numerous aspects of the experiences our patients described. Developing a solution for this disconnect does pose challenges, most notably the challenge of coordinating communication among different clinical practices and physical locations. As this is not necessarily a solvable disconnect, we think that technological aids will need to be designed in the midst of that disconnect. A solution will need to extend beyond simply sharing information. Future work should explore designing communication technologies to facilitate developing a consistent narrative for the patient. Doing so would mean coordinating not only the patient's current status and treatment plan, but also where the patient currently sees themselves in their own recovery journey. The next observed disconnect was divergent orientations towards tracking between the clinicians and the patients. Our findings about tracking did expand on prior work. For example, prior work did find that some eating disorder patients reported that technologies such as recovery record were really helpful. In contrast, none of the patients among our participants were particularly enthusiastic about these tracking apps. Patients seem to have a stronger preference for technologies or tracking approaches that facilitated moments of triumph, which were opportunities to reflect on and appreciate the magnitude of their own progress in their recovery journey. Our results suggest that future tracking technologies would benefit from including different types of health data, both quantitative, food recording, as well as mood tracking, and qualitative, which are these moments of triumph that come usually more in the form of a personal journal. Even though our participants highlighted the need for reflective diaries, there are barriers to these diaries becoming collaborative. Our findings suggested that patients were often hesitant to share their reflective self-tracking with anybody. Therefore, it could be essential to provide patients with nuanced control over sharing of this qualitative information. So disconnects in collaboration in treatment teams are almost guaranteed to occur. Therefore, we're suggesting not ways to completely eliminate all disconnects, but to design in the midst of and while accounting for these disconnects. For example, it may not be feasible to have all clinicians working in the same space, but a way to ameliorate the negative effects of having clinician teams spanning several specialties and physical locations could be to produce standardized records that are shared between clinicians so all clinical stakeholders can work to create a comprehensive summary of the patient's treatment status so that all clinicians understand where the patient is with their physical and psychological recovery. I did touch on some of the potential design solutions for patient-clinician communication and the barrier of tracking, but I will briefly touch on how future designs can serve to support collaboration between the patient's support network and other heterogeneous groups. We found, which did not align with past studies, that support network members rarely discuss the patient's treatment trajectory amongst themselves or even with the patient. Support network technologies for eating disorder treatment need to support equally the emotions of the patient as well as the emotional labor those support network members perform. As a result, we suggest that in the case of eating disorder technologies, could serve to support communication among support network members and clinicians. This technology could be designed to reflect the multidimensional nature of the condition. That is, just as eating disorder recovery is a journey for the patient, it may also be conceived of and designed for as a journey for support network members as well. So our study had many strengths as well as some limitations. One of our main strengths was that we reached theoretical saturation with a very small sample. So by around our fifth interview in both the clinician and the patient side, we did reach theoretical saturation, as well as the 5 novel disconnects that we identified. We did have some limitations, our modest sample size, as well as a lack of a patient-clinician link. Originally, we intended to interview the patient and the corresponding clinician of that patient, but there we ran into issues, mainly being with insurance and the ability to meet with these clinicians. Future directions for the work, including gathering data on support network members, which is something that we did not accomplish in this study, but that is something that we think is very important to understand their experiences, as well as another future direction is testing the feasibility and acceptability of a technological treatment aid that focuses on eating disorder patients' treatment journey and bolsters collaboration between stakeholders in eating disorder treatment. Thank you all so much for listening.